just because of the numbers that we see. So at any given time in the United States, 1 to 3% of the population may be dealing with this. And these numbers seem to be rising, not falling. And last year, 500,000 carpal tunnel surgeries, over 500,000 were performed. So that turns into an incredible financial issue as well. Over $2 billion spent in the surgical treatment of carpal tunnel last year. So a lot of people, including our insurance companies, have an interest in this topic. So basic anatomy, 101. If you look at the slide, that green space, that is the carpal tunnel. So we can think of this as a true anatomic tunnel through which structures flow. And in the human carpal tunnel, we have 9 tendons and 1 nerve that pass through this normal anatomic structure. So the yellow nerve is the median nerve, and that's the problem child here. That's the nerve that's getting inflamed and angered and causing all of our symptoms. So you can see there, the back of the hand or the back of the carpal tunnel is made up of bones, and the volar side, I'm not sure if you can see the arrow on the screen here, the palmar side is made up of this soft ligament called the transverse carpal ligament, and that's what we release in the surgical correction. So the areas of sensation that are disturbed with this are indicated in the blue field of this hand. So it's typically the thumb and then the more thumb-oriented 2 digits of the index and the long finger. Sometimes the ring finger is involved, sometimes it's not. Just kind of depends on how we're wired. So the other images kind of depicting the same thing. There is some involvement of the back of the fingers, but not the entirety of the back of the fingers. And in my practice, we don't really go into this much because it's so variable between individuals. People have that, people don't. It really doesn't give you a lot of information. So I think the main thing from this slide that I want you to remember is it's truly a pressure phenomenon. As we go through things, if you keep that in mind, it helps everything kind of come together. The numbers here aren't really important other than normally in a carpal tunnel, you're somewhere between 2.5 to 10 millimeters torr, whereas the pressure in an inflamed carpal tunnel, pathologic carpal tunnel syndrome situation is roughly 5 times higher than that. So it's not close. It's, dramatic pressure differences are causing these problems. And it really, you can think of carpal tunnel in 2 different flavors, acute and chronic. For our purposes, generally everything that we're going to be talking about is chronic, but there are acute cases as well. But it all makes sense under the understanding of this is a pressure situation. So an acute carpal tunnel is when you have a large increase in pressure during a short period of time. And that's not what most people present with. This is when you fall off scaffolding, break your wrist, and you also have a carpal tunnel. But the vast majority of the situations we counter in clinic are going to be a chronic compartment situation. So acute carpal tunnel is large pressure, short amount of time. And we really want to get to that in a hurry because instead of just a 5X situation where there's a lot of pressure, you can have a very dramatic increase in pressure, much greater than 5 times, and that can cause irreversible damage pretty quickly. Whereas in a chronic carpal tunnel situation, it's a smaller amount of pressure increase, still a lot, but a smaller amount compared to the acute situation for a long period of time. So this is the vast majority, and anybody that's out there listening to this with these conditions, you would be in this chronic carpal tunnel. And if we look at the chronic carpal tunnel category, we can think about those in 3 different ways. Idiopathic, which is one of my favorite words. Idio, which to me means idiot, and pathic means, which I don't know why it hurts. We call that about 40 to 50%. I think it's actually more common than that because a lot of times we can't figure out, what's the underlying cause? Why did you get this? If it's not structural, if it's not systemic, it goes into that idiopathic basket. And that's the vast majority of people. I think it's greater than 50%. But when we start looking at treatments, it really doesn't alter the treatment protocols very much. So this is more in our thinking how we look at it, but it doesn't really affect what you as a patient would, the pathways that you would go through. So structural, pretty rare if you have a ganglion cyst, a tumor, some other mass occupying lesion in the carpal tunnel. What we're trying to show here is one of those lesions that are kind of pushing things out of the way that can cause carpal tunnel, and that makes sense again because of a pressure phenomena. If you had a trauma, if you had a break in your wrist, and the normal anatomy of that wrist is deformed, in one way, it could also decrease the space and cause an acute carpal tunnel situation. And sometimes people are born with muscles that extend out of the forearm and into the carpal tunnel where they shouldn't be. That can contribute to the situation, but typically you only really know that after the surgical release, and that's a pretty rare situation. There are things from a overall health, systemic body health perspective that can feed into carpal tunnel situations. Inflammatory conditions, the most common being rheumatoid arthritis, neuropathic conditions, I guess, neuropathic conditions, anything that involves the health of the nerve can make that nerve more susceptible to carpal tunnel syndrome. Diabetes related changes are probably the most common that we see. Fluid balance, anything from just eating a bad inflammatory diet to pregnancy to you're just having a difficult time with swelling can increase the chances that you're could be dealing with a carpal tunnel situation. Hemorrhagic disorders, pretty rare in my practice. So the inflammatory conditions, just kind of a catch-all list, rheumatoid being the most common that we see on a regular basis. Neuropathic, I think we mentioned a couple of those. Almost anything that involves your endocrine system, thyroid also being prominent, can make you a little bit more susceptible to carpal tunnel syndrome. Fluid balance, we talked about pregnancy, and that kind of gets a special consideration because we know that is a temporary situation. So we try to manage that a bit different than situations that may not have a kind of an end date for them. Renal disease, thyroid disease, obesity. Some of these things we can treat with modifying the management of the underlying disease. Other things we're less successful with that, and we just have to deal with the carpal tunnel. So this is a huge topic here, exertional. People come in and they say, well, I use my hands a lot, and that's why I've got carpal tunnel. And the correlation between what people do at work or at home or for hobbies and carpal tunnel, it's hard to really get at that. And in the literature, we don't have a lot of guidance. There's, as we mentioned, huge financial considerations with how these questions are answered. Because if every time you move your wrist, you get carpal tunnel and you move your wrist at work, then and that means they have to pay for that. That could be a very big financial burden. And truly scientifically, we don't have this worked out either. So uh, I guess agnostic would be the way you would grade it now. Science doesn't really speak to this to say that, well, if you type, that's the reason, or you work a keyboard, that's the reason why you have carpal tunnel syndrome. And before you get mad at me, that's not my opinion. That is the consensus opinion. And the American Academy of Orthopedic Surgeons, that's our kind of highest body in the field. And they came out with a position statement several years ago that confirms that we don't have specific recommendations for carpal tunnel syndrome with certain subtypes. The important one here being the last one listed, carpal tunnel syndrome in the workplace. So, you as a patient, how do I know that you have carpal tunnel syndrome? So, you would schedule an appointment, come in, and we would do the basics. We would take a history, physical examination, and I put some of these slides in to include that this is just not what I think as one person here in East Tennessee. This is based on the best science we have and consensus views from the American Academy of Orthopedic Surgery. So they think we should actually talk to a patient, which I think is a pretty safe position to take. They also think we should perform a physical examination. Again, it's hard to see how that's only a grade C level recommendation, but I wasn't involved on the committee that came up with this, so I won't be too critical. When you have a physical examination, we perform several different tests that's routinely done pain free in the office. We tap on the nerve to try to elicit a electric response, which is very specific for carpal tunnel syndrome. We put the nerve in a temporary compressed state to see if that reproduces the symptoms, and probably not as much pressure as that gentleman is putting on that guy's wrist. We apply pressure directly to the wrist and see if that reproduces symptoms. And when you take these things into consideration with other findings, it gives a very accurate uh, answer as to whether or not carpal tunnel syndrome is truly causing the symptoms that brought the patient in to see us. Motor weakness, of course, that nerve carries motor as well as sensory fibers. So besides just pain and numbness, we can see some loss of strength, and we can actually see atrophy sometimes on the thumb side of the hand. But that is a pretty late finding. By the time we get to motor weakness, we might have some irreversible changes. So we don't like to wait for that. We want to fix it before we see permanent, irreversible, damage to the nerve. Electrodiagnostic testing, we use this on occasion. Its practice varies with individuals. I think I use it less than most. It can be nice in a case where there's some question. Do I have a pinch in my nerve or my elbow as well as my wrist? Or I have really severe diabetes and my feet are numb. Could I have carpal tunnel and diabetic neuropathy, or are they different things? The nerve study is a good tool to help ferret out some things when there's some complexity, or maybe you had a release 40 years ago and now you're having similar problems, which can happen. That would be a good time to look at this. So there's different situations where it's a good tool, but routinely for straightforward situations we don't often get electrodiagnostic studies. And that's also the standpoint of the American Academy of Orthopedic Surgery, that you don't have to obtain electrodiagnostic studies to proceed on with treatment. Some insurance carriers more recently have had issues with that and have been more aggressive about obtaining electrodiagnostic studies for most carpal tunnel patients. So there's a little bit of push and shove along that right now, and hopefully we get that cleared up. So imaging, we don't do a lot of additional imaging because it's not needed. So if you go and see someone for carpal tunnel and they don't get an X-ray, they're not underselling you, undertreating you. The diagnosis is made from the history and physical exam, and sometimes the electrodiagnostic studies, X-rays, and even MRI and ultrasound are not very beneficial for the most part. There are some studies going on now with ultrasound to see if we can um, substitute ultrasound as a secondary study instead of the electrodiagnostic studies. But that has not been found to be very reproducible because it's very technician dependent. And I think the gold standard still is with the electrodiagnostic study for a backing examination. So AAOS says the physician should not routinely evaluate patients with new technology, MRI, CAT scan, et cetera. And I think that's right. It adds a lot of cost and thus unnecessary trouble to the process of getting treated without a lot of benefit. So when we talk about treatment, we basically have a dichotomy, operative and non-operative. And as a general rule, we try to maximize non-operative care. And if that doesn't work, then we go to the surgical options. The non-surgical treatment that, in my opinion, works overall best with lowest difficulty and cost is nighttime splinting. And we take a splint. Sometimes it's one that the patient already comes in with. We bend it to neutral or a straight on position, and we just have the patient keep that splint on at night with the wrist in a 0 degree flex or just a naturally straight position. That's keeping the carpal tunnel space as open as it can be. If we think about it like a garden hose, we don't want it flexed or extended to limit flow. For 6 to 8 hours a night, you keep the thing perfectly straight and see if that decreases the inflammation. And if that's going to work, we normally see those results in 2 to 3 weeks because that's very easily tolerated. Anybody can do that. You don't have to wear it while you're working. That's a great first option to try. Medical management makes more or less sense based on the overall condition of the person. If you're healthy and there's no medical issues, then there's not much to manage there. But if you're a cardiac patient and you've put on 20 pounds of fluid because you haven't been taking your medicine in the last couple months, then there may be gains to make with that. Oral medications and corticosteroid injections. Oral medications are typically tried before people come to me. They'll take some anti-inflammatory, or their primary care doctor will do that first. Corticosteroid injections, I have some probably stronger feelings on than most people. I don't like that option, except for in selected positions, because I don't like the downside of it. There have been cases where the nerve was injected with corticosteroid, and that can be damaging. So, in some ways, I think that the injection is more risky than the surgery. But if a patient is adamant, if they want to try that and they understand the risks, I think that is an established, understood treatment, and we perform that procedure as well. So here's an example of the steroid shot. We can do that in the office. We put a little local in the cocktail as well as the steroid to try to make it less painful. Uh, the shot takes under a minute. It's rarely curative, and it's typically more of a stopgap measure, a temporizing measure. Sometimes we'll use that in pregnant patients to try to get them through their pregnancy before we can do anything more definitive. American Academy of Orthopedic Surgery, they come in and say, yep, we recommend doing the carpal tunnel surgery that's been done since 1933, and we're okay with that. Steroid shot, splinting, that's an okay thing to do. Um, Oral steroids, ultrasound options, but you can see the grade is a little less. And other things like heat therapy should not be used. They do recommend trying non-surgical things first, except for when the atrophy or the severity is so great that we have more of an acute situation. We don't want to waste a lot of time and maybe get less results because we waited too long. If we're talking about non-surgical treatment, we don't want to do that forever. We feel that giving it 2 to 3 weeks based on the literature is normally long enough. So if you haven't seen results from a splint in 2 to 3 weeks, waiting 3 to 6 months is not indicated in the literature and not the current recommendation. Adjuvant treatments, so other kind of things. There's a lot of stuff out there. People have tried lots of different things, because if you could find something that worked for so many people, because this is a very common condition, there'd be a huge economic payday for someone that could come up with another idea. Um, but in our experience, there's not a lot of Western scientific evidence supporting things like magnet therapy, yoga. Not that yoga is bad, but for the treatment of this condition, vitamins. There's just not the science behind that. Sometimes people say, "Hey, I want to take B vitamins for a couple weeks," and I'm like, you're welcome to do that. I don't see a downside. But as a Western scientifically based professional, we just can't speak to that because the literature is not there. Surgery, which is what we do. For cases that don't get better. So chronic refractory carpal tunnel, we try the splints, things aren't improving. You rub stump water or whatever your favorite thing that your grandmother told you, and it's not getting better. Surgery is a consideration. When we see atrophy or wasting of the muscle, things that are going to get worse over time, we typically get more aggressive. Sometimes we'll have people that come and say, "Hey, I've had this thing for 20 years. I've tried these things. I know what I need. I just want to get this thing fixed." We will fix those patients. Surgical release, how it works is we release that transverse carpal ligament. So if you can imagine, that space goes from a more compressed to a more voluminous. So high school physics, increased volume equals less pressure. We increase the volume, we decrease the pressure, and we cure the symptoms. The first thing that gets better, and it's normally within 24 to 48 hours, is that resty, achy, shaky night pain that patients complain of. The sensory issues in the finger, the numbness, tingling, burning, that can take longer to get better. It can be better within 24 hours, or it may take several weeks. Occasionally, if the symptoms have been longstanding and severe, we don't get 100% of the feeling back. So if that nerve's been stepped on, hasn't got good blood flow for 20 years, you may not get 100% of the feeling back. And people are fairly intuitive. They kind of know that coming in, but it's worth the effort just to get rid of that, pain that's waking them up every night. The motor findings, if you look into the topic, it's normally regarded as irreversible when we have motor atrophy. I've been surprised. I'm convinced I've seen cases where people seemingly do get a lot stronger. They do get some of that thenar or thumb muscle back, but it may be a situation where they were painful before, and we take away the pain, and they feel as if they've improved. So I may have been fooled there, but seemingly the motor is mostly a done deal, but sometimes we do get some improvement there, I think. So, how do we do the release? How do we do the surgery? There's been an evolution over time, and not all evolution is favorable, and sometimes there's some downside, and that's what that slides is meant to remind me of. Essentially, these were all done open for 50 years. Then in the 80s, we started doing some mini open or trying to decrease the length of the incision, and then late 80s, early 90s, we began to develop endoscopic techniques where we could do it through even smaller incisions with the use of more technical equipment. So, which is best? It really does not matter as long as the surgery is performed correctly in the long term. So, there's some advantages and disadvantages to each technique, but at 6 months, as long as the correct surgery or the surgery is performed correctly, everybody tends to be equal. So there's an open incision, the traditional way of doing it. And I would say that 85% of my patients have this technique. We can do that with you awake or asleep. The numbing medicine goes in through a shot. We give it a few minutes, let it numb up, take you back to the operating room, do this release. The surgical time takes about 5 minutes. Stitches that stay in for 2 weeks, no splint, no cast, no therapy, just a dressing for 5 days, and light activity begins immediately. So if you do a lot of keyboard work, emails, you can go back to that next day. If you're a lumberjack, you're going to be out of work for a little bit because it's harder to do kind of heavier stuff for a while. The mini incision, I don't employ commonly. I don't like working through a keyhole. I don't think I can do as good of a job, and I don't feel like there's much benefit from that. So I don't make incisions this small because I don't think I can do a complete release and do a good job. Other people will employ some derivative of this, a smaller incision, but in my practice, I just don't think this is a great option or a safe way to go. So if I need to go with a less invasive procedure, I just go to the endoscopic, and about 10 to 15% of my patients will have this. The biggest downside is it's just more complex. You have to go to sleep. So a general anesthetic, sedation is employed with this. Surgical time is 5 to 10 minutes. You wake up, you go home. Of course, it's an outpatient surgery. There's no real change, but for the fact that we don't make that skin incision between those 2 points. And if you are that proverbial lumberjack employee and you're trying to get back to work as quick as you can, or you use vibrational tools, or you're a mechanic, it may make sense to undergo this procedure with a little more complexity to try to get you back to work quicker. And that's not just my opinion, that's actually been shown in the literature that we can get people back to work a week or two earlier, depending on the kind of work that they do with an endoscopic technique. So if you're a firefighter and you're trying to get back as quick as you can, we would consider doing this. So both of these techniques are well explored, well established. Both have been done for over 20 years. There's a little bit of different profile in terms of, you know, side effects or issues you could have. But I think the take home here is that less pain for several weeks after the surgery from the endoscopic technique. And this is kind of a just a quick picture of how this goes in the operating room. Patient's asleep, the scope goes underneath the carpal tunnel, and this scope is slotted. So this picture, you're actually in the inside of a cannulated um, instrument, so you can actually release the ligament through the slot at the top, and that's what we do. So this is a released ligament, which is essentially the same surgery that you do from an open procedure, but In this case, you're doing it from the inside out. And I think that's as technical as I need to go with that. Specific questions I can address, but just a last couple of notes. Antibiotics, sometimes people they have lots of medical conditions, and that makes sense. But if you're a young, healthy person, antibiotics really aren't indicated, and we don't use those. Other medication issues. If you take NSAIDs, you can keep taking those. If you take a baby aspirin, or if you're on anticoagulation, normally, I don't stop those, and I have not had a problem with it. Um, Kind of final thoughts here. Again, long-term open versus endoscopic, no difference. Short-term endoscopic's a little bit better, but different complication profiles and a little bit more involved in terms of your throughput, your day if you're going to sleep and doing the endoscopic approach. Both work well. I would say we're closer to the 98 than the 81% range. I think in orthopedics, the two best surgeries that we have are carpal tunnel releases and total hips, because people come back at the 2 week mark from both of those. And a lot of cases, they're better than what they started with. So that's a pretty quick turnaround. Rehab, not everybody wants to go to rehab, and that's okay. We don't typically employ it. After the surgery, begin early active range of motion, no heavy lifting, and only in rare occasions where people are having an issue would we think about doing any type of formal rehab program. AOS also suggests that we get people moving quickly. Studies have actually shown people do better if they don't use a splint after the surgery, which was commonly done decades ago. This is a friend and coworker, a former PA of mine down in Florida, and a reminder for me to tell you, not a good idea to do both at once. James is a very tough guy, didn't want to miss any more work, told me, hey, I'll be okay if I do them both at the same time. And I told him I didn't think it was a good idea. We did them both, and he probably missed more work than he would have if we'd have done one and came back and done the other one later. So in terms of bilaterality, if you're having both symptoms both in hands and you want to take care of both of those, I still think it's a better idea to do one, get a recovery, and then go for the second one. Because if you do both, it's just so hard to let a hand rest. Even small activities like hygiene, open the refrigerator, it's going to keep that inflammation going in that operated hand. Whereas if you can rest it and use the other hand, you're going to get to the finish line quicker than if we try to do them both at the same time, in my experience. So I think that's the formal talk. Appreciate everybody's participation out there in TV land. Thanks for listening.
Thank you, Dr. Branham. I'm going to pull my chat function up. If anybody has any questions for Dr. Branham before we end, type them there. While we're waiting to see what questions come through, I was just going to let you guys know this has been recorded, so we will email it out to all of you guys. Also telling you 3 different ways you can schedule with Dr. Branham. You can call us at 690-4861. You can go to TOCDOCS, TalkDocs.com, go to Dr. Branham and schedule online, or you can email us at feedback@TalkDocs.com, and I will help you get scheduled with Dr. Branham that way as well. And if you have any question that's kind of longer and maybe don't want to type it all out, if you will just type unmute me in the chat box, I will unmute you so you can ask Dr. Branham. I see